Okay, no major disclosures. I'm a pelvic floor physical therapist, and so when we start looking into that, for those of you who don't know, many of my common treatment approaches for incontinence will vary from pelvic floor muscle training to biofeedback, various aspects of education, scar care, scar mobilization when appropriate, bladder retraining, pelvic floor muscle training with functional integration, posture, body mechanics and lifting, lifestyle modifications, core stabilization, electrical stimulation, and many other techniques. Dry needling is another thing I use as well. But what if physical therapy is not working? It's my job to figure out why it's not working, not just send the patient back to the doctor. Sometimes is there a compliance issue? That can be a problem without a doubt. Is the patient just not interested? If the patient doesn't want to buy what you're selling, you're wasting each other's time. So you either need to motivate them to be interested in physical therapy or then consider other treatment options. Or are they not actually understanding what their body is supposed to do? Or is there a motor learning problem? So I want to present a case here. And this is on a 64-year-old man who works as a janitor. So he has repetitive lifting of 10 to 20 pounds. He had surgery for a prostatectomy back in April of 2016, so 6 months ago basically. He was evaluated on June 16th of this past year, not by myself, but I was brought into the case. So at that time, he reported being able to have an erection 100% of the time, but yet he was withholding water to decrease his urinary leakage, because he was using about 6 large incontinence pads a day that he was soaking. His strength was a 4- out of 5, and he was very motivated. So right there in that information, I hope you think it's conflicting information, because it is. He attended 4 physical therapy treatment sessions at one time a week with little to no change. And he was compliant. He was almost too compliant. So he was reevaluated on July 22nd, and that's when I was brought into the case. At the time, he reported he was still using 6 shields a day, and he was still withholding water. So that should be concerning. So my objective findings, without getting into the whole reeval, his hamstrings were tight, 48 degrees on the right and 46 degrees on the left. His pelvic floor strength was actually a 3- out of 5. And he was bearing down and holding his breath. He had a diastasis recti of the abdominal muscles for 2 fingers above the umbilicus, and he was unable to isolate or activate his transverse abdominis muscle, whether in sitting, standing, or laying. So I sat down with Richard, and I said, tell me what you're doing at home. And as you're talking to him, he was saying everything right. And so once again, it made no sense why he was still having the problems he was having. So then I said, okay, let's have you change into a gown, and I want you to show me everything you're doing. And this is so important. Whether you're a doctor or a physiotherapist or nurse or whatever, this is really critical, because Richard was telling me everything perfectly, what I needed to hear, but then when we had him start to demonstrate, that's where we started finding dysfunction. You need to ask yourself, are your patients holding their breath? And you really need to look for different compensations. So once again, he was reporting little to no benefit after 4 weekly visits. Now, I don't expect him to be cured in that time, but you should see some type advances. And we should be asking ourselves, why is this not happening? Why are they not progressing? So after reassessing what were the underlying problems I was finding, he was having an improper pelvic floor contraction. And it was really interesting because Richard and I had a discussion about this, because I was trying to tell him we need, a lift and a pull, or a lift and a tightening, and we agreed that he was having a lift and a push. And the push ultimately was he was bearing down. So initially he was activating the muscles, but because of the motor pattern learning he had, he was actually doing a lift and then bearing down. And also, he subconsciously was holding his breath with many things he was doing. Even with talking with him, asking him about his work patterns, he would hold his breath as he was telling me things he was doing at work. Also, there was Valsalva with lifting techniques. I brought him into our lifting station and said, okay, show me, let's pretend we're taking garbage out of the pail. Show me what you're doing. And he was Valsalvaing each time he was doing that. And there was a lack of integrating with the abdominal muscles. It was like they were, in a different room, and he was not using them to support his body and overall muscle fatigue. So the treatment involved everything from diaphragmatic breathing to teaching him to avoid bracing and valsalving, changing the pattern he had, pelvic floor muscle isolation with constant verbal cues to breathe, putting him in different positions, and asking him to use a 25% effort, simulating work and retraining of breathing to avoid valsalving, abdominal activation and isolation, and of course hamstring stretching. So 5 weeks later, so just recently on like September 2nd, he reported being 65 to 70% improved. He went from 6 pads a day down to 2 pads a day when not working and 3 to 4 pads a day when working, and noted that his pads are not soaked anymore, there's less leakage on the pad, and that he has returned to drinking fluids normally. So right there I see huge success, but yet my brain is still saying, why does he need 3 to 4 pads at work? And so his future treatment's also going to involve more work simulation, watching for holding his breath, how is he activating abdominal muscles. And so that leads me to, many people think pelvic floor muscle training is just contract, relax, contract, relax. But are they truly able to contract? Are they having a right motor pattern? Are they able to relax? Are they bearing down to compensate because they can't hold it? What is the quality of contraction? The strength and the endurance, the timing of the contraction? Breathing, are they holding their breath because they're trying to get more strength? I see that repeatedly. Effort, a lot of times we ask patients to use their max effort, but many times I find a better contraction when asking them to use 25% effort or 50% effort. Are we identifying hypertonic muscles or hypotonic muscles? What is the posture they're doing these exercises with? And what is the coactivation of other muscles and muscle compensations? So with Richard, I just need to bring this up because we know the effects of prostatectomy, the physical effects from, the different surgical approaches to the removal of the prostate, to loss of smooth muscle, to potential damage to the striated urethral sphincter, possible loss of sphincter muscle, and damage or irritation of the nerve supply. However, we need to address the mental and emotional effects of the prostatectomy as well. With Richard himself, we are referring him to counseling for just more support. We've given him information on support groups and just the emotional factor. Many men I work with post-prostatectomy have a hard time acknowledging the fact that they have cancer, and also they feel that losing their prostate is a loss of manhood, and we need to give referrals as appropriate. And it's important when we start looking at research, many times the research has shown in pelvic floor strengthening, which if you look at overall is unreliable and conflicting data out there. Men are told to tighten around the anus, commonly used in research, is not effective. And it's important to look at different cues. Stafford et al. In 2016 is looking at the cues that we're giving to men to activate their pelvic floor. An example is using different cues instead of pulling around the anus. Try to pretend and stop the flow of urine to prevent from passing gas. Pretend you're a turtle and pull the head into the shell. Not all these come from Stafford, please. And shortening the penis and other cues as well. But we need to, Stafford did show that there's 2 different dominant muscle activation patterns found in men with pelvic floor muscle activation. You can get a striated urethral sphincter dominant pattern, which is more of a compressing, or a puborectalis dominant, which pulls up towards the pubic bone. So the striated urethral sphincter pattern responds best to the cue, shorten the penis. So with knowing that research is out there, what cues are we giving our patients? Do you palpate and feel which cue gets more muscle recruitment? What do you feel, and what does the patient feel? And many times when you give different cues to your patients, they will respond differently and have better muscle activation patterns with different cues. So questions to ask ourselves: are the correct muscles being activated? How do we know? Is the patient overcompensating? As I mentioned earlier, if we're told to do something as hard as we can, what happens to your breathing pattern? We tend to hold our breath. So that's giving us the wrong approach. We look at different muscle assessment from palpation to ultrasound imaging to surface EMG to biofeedback. There's many different tools we have. We need to be using those tools. Sherburne et al. Showed that real-time ultrasound is a non-invasive option that is valid and reliable to assess the pelvic floor muscle function. Also, Stafford et al. In 2012 said there's novel insight into dynamics of male pelvic floor contractions through transperineal imaging. So we have many options at our hands. Should we train other muscles besides the pelvic floor muscles? There's over 45 different muscles that attach in and around the pelvis. And Sapsford et al. In 2001 proved that the pelvic floor muscles work in conjunction with the diaphragm. The transverse abdominal muscles work in conjunction with the multifidus of the spine. The diaphragm is the roof of the pelvic floor muscles and the foundation. They need to work together. Pelvic floor muscles will get co-contractions with the transverse abdominis and the multifidus. So we need to look not only at the pelvic floor muscles, but what the muscles around are doing. So what if it's not working? So we need to teach patients patience and realistic expectations, and explain to them the importance of compliance, understanding pelvic floor contraction, getting the proper, elicit reaction, and going deeper into using biofeedback or e-stim if appropriate. Use different cues, work with different muscles to assist, get more involved, use other PT techniques or incontinence tools, and talk with the doctor or send them back to the doctor. So the take-home messages I'd like to share with you today is with incontinence, there are many valid treatment options, but pelvic floor muscle training is recommended as a first-line treatment. But make sure the patient is doing it correctly. You need to individualize a program for your patient and use different cues to get better pelvic floor muscle activation. When we say to treat the whole person, treat their whole body, not just their pelvic floor. And resolution of muscle dysfunction is essential to improving quality of life in men with incontinence. Were we going to open up for questions, or Dr. Hubbard?
I think we should open up for questions. That was very good. Thank you. Are there any questions out there? I think it's really nice that you pointed out that you need special cues to make things work. I think that's my take-home message anyway.
Well, I think there's great research that's been coming out in the past 5 years really addressing that, where the previous research has just said to tighten the anus, or doesn't really explain in the research what they are doing to activate the pelvic floor. Also, when we look at research, you need to look at who is instructing on the tightening of the pelvic floor. Is it a physical therapist? And my question is it a physical therapist, or is it a pelvic floor physical therapist? Or is it a physical therapist who went to a one-day course on how to activate the pelvic floor? Because I can tell you very sincerely, in doing this for over 15 years myself, if you would have talked to me 5 years ago and talking to me now, there's a very large different approach in how I approach strengthening of the pelvic floor, and experience really helps you understand. And with the case I presented today, initially the person who availed that patient was actually a pelvic floor intern. And she was missing how that they were contracting, but then they were also bearing down. So it was the lift and the push. And it wasn't really truly a 4 out of 5 on a strength scale. So seeing the importance of people who really understand the proper strengthening. So, any questions?
Please, could you tell your name and from your origin, and walk to the phone?
Hi, I'm Ingrid Davis. I'm a physiotherapist who'd like to do more pelvic floor, but I'm at the start of my journey, so I apologise if this sounds a bit silly.
No, thank you for being here.
You talked about the two different types of dominant patterns of contraction. Is one preferable to another in your opinion, or do you encourage the one that person seems to respond to? And I apologise again if that's an obvious question. Yeah, go ahead, sorry.
Well, I think what we're seeing here, and it's the research that's coming out, is showing, and it also leads back to when you're looking at post-prostatectomy, what actually, you can look at what is the preferred pattern in the patient, and then depending on the surgical outcomes, do we need to teach them another pattern? You know, is it the striated urethral sphincter, or is it puborectalis? Approaching it from that way, which would be, you know, and what was the surgical outcome and the damage to that surrounding areas. Okay. I think the big take-home message, whether you're working with post-prostatectomy or incontinence in general before that, is using different cues and finding the best muscle recruitment pattern and seeing how that can be applied to your patient.
And with the puborectalis dominant lift, what cue do you tend to use when you're trying to encourage that? Is there a message that you give your patients? Verbal cue?
Actually, I don't specifically. I mean, right now I'm kind of changing my pattern in that based on what the research is. I once again I usually work while I'm doing an internal rectal palpation and watch for their breathing, watch for muscle compensations, and then just seeing which is a better muscle recruitment pattern and have that patient work with that one. Yep. Research has shown it's definitely not tighten the anus. So it's better to say, you know, shorten the penis, elevate the bladder. So there's different cues.
Okay, thank you.
Please come to the microphone.
Don't be shy.
Hi, Heather. As you know, I'm Paul Hodges from Australia. And I just wanted to respond to that question a little bit. Tomorrow morning, I'm giving a presentation about the different presentations of pelvic floor muscle dysfunction in post-prostatectomy incontinence, and exactly align with what Heather's just said. What we've shown is that there are some men where the biggest deficit seems to be in the sphincter, and other men where it's the puborectalis. And the biggest thing with puborectalis is not necessarily that they're not activating it well, but they're beating it by contraction of the abdominals pushing the pelvic floor down. So what our hypothesis is that if we can use specific assessments to work out where the deficits are, we may be able to direct the treatment specifically to match the deficits that we found. Yeah.
I have to give a shout out to Paul Hodges because him and his lab are basically where this research is coming from, and it's just shedding light on a whole different approach to treating male incontinence. So thank you. Any other questions?
I think it's not a question, it's more a remark. What you show us here, I'm Marcus Leek, a physical therapist. What you show us here is that incontinence is not just a trick by pelvic floor exercises, and that a musculoskeletal specialist is looking from the top to the bottom. It's not an easy trick to hold, contract, and relax. It's much, much more than this. And this case is demonstrating very clearly. And this is not a very special, unique case. It's not. I mean, this is our daily practice, but you are demonstrating the complexity of the physical pelvic floor therapy. So thank you for that.
Thank you. And just to add into it, that's why I picked out in my findings to show that there was problems with the pelvic floor, there were problems with the breathing pattern, there was problems with the transverse abdominis, and there was even problems with tightness of the hamstrings. And why does that matter? Well, we need to think about where the hamstrings attach and how can that affect the pull on the pelvis from everything from walking to lying to any activity that patient is doing. Any other questions? Nope. Okay.